Okay, so
Already.
Senator Hardy, we're looking at S14 and welcome. So why don't you give us a high level, just a really high level view of what is in the bill?
Okay.
Minutes.
Thank you, Madam Chair. For the record, I'm Ruth Hardy. I'm from the Addison District. And S14, which I would like to pull up, so I have it for
For Dr.
sure.
Dinosaur Pregnant Individual.
Yes. So as some of you may recall, last year, there was a comprehensive bill that was introduced regarding expansion of Medicaid programs on a number of levels. It included expanding Medicaid up for young individuals, for young adults, for expanding the eligibility levels. It also included some provisions about Medicare savings program, and it included this provision about expanding eligibility for pregnant individuals. The Medicare savings plan was the piece of the legislation that we were able to move forward last session. That was a great thing we were able to do for older Vermonters who are transitioning from Medicaid to Medicare. And the healthcare advocate would love to talk to anybody about that. And then this piece was something that we thought we could try to move forward this session. For Medicaid eligibility for pregnant individuals, right now, the eligibility limit is 208% of the federal poverty level. And I know you have up on the wall the poverty levels. For Dr. Dinosaur, which is the program for kids, the eligibility level is 312% of federal poverty level. So what this bill would do is move pregnant people from 208 to 312. So when somebody's pregnant, they can get the prenatal care and all of the stuff that they need in order to deliver a healthy baby, so that the mom and the baby are both on the same eligibility level. And then when the baby's born, it will be an easy transition to stay on the Dr. Dinosaur program. It also includes some language about coming back to us with a report on whether or not other expansions are possible, which is even more important given everything that seems to be happening in Washington. But really, this is a bill that would provide more pregnant women, the ability to get vital prenatal health care so that they can deliver healthy babies.
Terrific. Okay. Questions for Senator Hardy? That's a good introduction. Thank you.
Yeah, and Jen obviously will go through the details.
Oh, yeah. We'll go through it. We're going to go through it in a little bit. Any questions?
I'm just glad I read the bill. Great thing.
Yeah.
Excellent. Yeah. And I mean, obviously, unfortunately, not enough people are having babies in Vermont. They're fairly small.
Honestly, look at it. This might encourage people to have, there might be greater affordability for having children if they know their covered.
Yeah, absolutely. Absolutely. It's all making it easier and healthier for families in Vermont. But it also means on the plus side that the cost is not that, it's a fairly modest cost to
Yeah.
give
We'll
a
have
very
data.
important service.
We'll get
So
that. Thank you.
you're welcome. Thank you.
And as you know, this is one of many bills up there. So, and we have a two years of the biennium, but I'm thinking that this is something we might look at sooner than later. And there are other bills that are more complicated that we'll have to get in line.
Yeah, I mean, this one's pretty straightforward comparatively.
It is. So we'll have to do that little bit of analysis and see.
Thank you, Madam Chair.
All right,
Nice to
good.
see everyone.
All right.
Thanks, Senator.
Thank you.
All right, back to work.
Yeah, back to renewable energy standard.
Cool.
Bye. Bye.
All right. Oh, well, we have the sponsor of the next bill with us right here. Do you want to sit at the end of the table?
Sure,
Oh, good.
why not? Let's do the whole piece of theater here, which involves moving to this seat.
You'll be sorry
I'll be sorry.
that you moved to that seat.
Oh, but we changed it. This isn't the creaky one anymore. Or is it? Oh, it is the creaky one. It is the creaky one.
Well, just to stand patted, did you?
Well, I'll make it short. Good morning. For the record, Senator Martine LaRock Kulik. I'm happy to be here today, and I'm really thrilled to be introducing S18. As someone with lived experience in this area, I'm so excited to be talking about the possibility of having freestanding birthing centers in the state of Vermont. By freestanding, all I mean is that it will not be part of a hospital, but it'll be its own independent facility. So what can I say about freestanding birth centers? They give pregnant people an option as to where and how they will deliver. Right now, the options for most folks are a home delivery or a hospital delivery. And that was the dilemma that I was faced with as well. So this just gives folks another option. I can tell you that birthing centers are already in existence in all of our neighboring states, and very popular in New Hampshire, as a matter of fact, and that they are very successful. We are one of only 8 states in the entire country without a freestanding birthing center. One fact is that a lot, or I shouldn't say a lot, but some of our healthcare workers are actually leaving the state to go and work in our neighboring states because they do want to provide care in a freestanding birthing center. So we know we don't want to lose workforce. That is a huge problem. Having a birthing center in the state of Vermont would mean that we would keep some of these critical healthcare providers. Health outcomes, I think we all know that health outcomes are critically important, and birthing centers have been shown to reduce maternal morbidity, increase infant-parent bonding, and increase breastfeeding initiation rates and duration. These are all so important to the long-term health of a child, as well as, frankly, a family. Birth center C-section rate was 6% compared to 26% for low-risk pregnancies in hospitals nationally, and preterm and low birth weight babies were reduced by 50%. So these are data points that just cannot be ignored. They are very compelling. Birth centers work in partnership with hospitals. They are not in competition. Pregnant people looking for this option, as I said before, often leave the state and they travel long distances to seek this care. Affordability. I know a lot of folks are wondering, is this going to put more of a stress on Medicaid? Is this going to mean more money? Absolutely not. Births are already covered by Medicaid and by private insurance. So this is not an expansion. By moving births into birthing centers, we will actually save money. Researchers have estimated that more than $30 million was saved over 3 years. $30 million was saved over 3 years because 15,774 women chose to have births in a freestanding birthing center instead of a hospital. I think I covered most of what I wanted to cover. I do have a sheet that I will hand out to you. And I know, a lot of our decisions this year are going to come down to money. So I do want to draw our attention to that. You may have gotten a handout from Blue Cross Blue Shield, but just for comparison, the cost of a vaginal birth at UVMMC is $17,100. Dartmouth, $11,582. In a community hospital, it's $6,904. And in a freestanding facility, $2,870. So you're looking at a difference of $15,000 in one birth. And that's not even talking about C-sections. That's not talking about early delivery or any other complication. That's just, a regular healthy vaginal birth. So that is what I have to say today. I will hand these out so you can read more, if that's okay.
And where do these come from?
These sheets come from the Vermont Birth Center Coalition.
All right, so when we take the bill up, we'll have those folks in, but like hand them out. If I want to hand them out
I'll
now.
hand them out from my seat.
Yeah, okay, good. Thank you. Questions for Senator Gulick about the bill? Go ahead, Senator Hart.
Midwives.
Yes.
I know in my district in Randolph, they have when you pull into the town, stoplight, you look to the left, they have a brand new building set up there just for midwives. I mean, a huge building. So I don't know if people coming in there for births or they're going, where are they going? I don't know that. I haven't stopped and knocked on the door, but I do know there's a big sign that says community midwife.
Right, midwife is a home visit person, probably. I will have to, well, what we will have to do, I think, is as we look at this, to understand the different options and
Yeah.
birthing center versus
I don't know.
midwife versus
Yeah.
hospital.
And most of the births are happening at Gifford.
I was gonna
Right.
say,
Yeah.
I would imagine they just don't do
Yeah.
births there.
Yeah.
But probably give care.
Senator Cummings.
I think my last pass through here, this came
Yeah.
up,
Yes,
I think it ended in finance. And the problem was, if you have a problem in delivery,
you go to the hospital.
right? But our rural hospitals are already, Springfield has limited OBGYN services for births because you have to have an OBGYN and at least one skilled nurse on there 24/7. And we are not having enough babies to cover that cost. So if we take out more babies, we're going to lose more OBGYN at the rural hospitals. And then if I have to go to Burlington or Dartmouth or Rutland, and I'm in a crisis, that
So
was the balance.
we're getting into the discussion and the
Yeah.
testimony that we need to hear. Should we look at, and when we look at the bill, so I'm gonna ask you to come back.
Yeah, if I could just say that the urgent transfer rate from a birth center is only 2%, and it is.
So Senator, I'm gonna suggest that this is where we're getting into
Yeah.
discussion and we'll hold until we have testimony. So you,
Can I please make one last point? Chair.
sure.
Which I neglected to make, which is that again, I like to bring it back to the Oliver Wyman report. They recommend this as a way of providing more accessibility and lowering costs.
You're right.
Thank you very
You
much.
were. That was a good link.
Thanks.
We're gonna look at that report next week.
I love that report. Thank you.
Thank you. And so, yes, there are a lot of different issues embedded within this one bill. Senator Douglas has a question for you.
Small question. You can say, you don't need to say.
Sam,
it.
thank you.
Yeah, would doctors be operating out of the centers or people that are able to perform C-sections?
That's a really good question. No, I don't believe so.
I don't think midwives are
Midwives and
able
doulas
to.
that will
Yeah.
be there, yeah.
Yeah, midwives. Yeah, okay, so. Thank you. All right.
Hiring points of our loved ones.
Thank you.
I know.
Well, no, so you can see this generates a lot of questions and ideas and interest in answering those questions. And our job is to look at these bills and decide which ones we want to pick up in earnest. And then get the testimony we need to answer the questions we have. Not the least of which is, does it save money? Does it keep workforce in the state and so on? But I would think we would want to look at this bill. So as Jen goes through the bills this morning, again, we looked at a number of bills earlier in the week, and then the CON bills, share something about those. But then we have these bills, so we have to think about which ones we're going to take up sooner and which ones we'll look at later. But I have a predisposition myself, but I hope you guys will also write that. So Jen, thank you for being here. And let's start with, I don't know, what do you think? Do you want to, if the agenda, doesn't matter which order the agenda goes in, but we have a lot of interest in the last one, the more questions and discussion. So why don't we start with that one?
Good morning, Jen Carter from the Office of Legislative Counsel. And just a caveat here, they're ringing the bell. I do have a House bill on the floor In
I
probably
know, and
not,
it's a.
probably not for another 20 minutes or so, but I,
Okay,
when the committee systems is
Do
gonna
what
let me
you can
know
do.
when I need to head upstairs, so at some
Okay.
point I will.
we have time here. If we have more time after you leave, we have some discussion we need to do, and then we have some procedural things to talk about offline, so we'll do that.
But, so here is S18. Room here. All right, so this is S18. This is an act relating to licensure of freestanding birth centers. And it creates a new chapter in Title 18 on birth center licensing, and it is modeled on the provisions we have already for hospital licensing and ambulatory surgical center licensing. So that's kind of the structure. Starts off with a definition. So a birth center is a facility that is not a hospital or part of a hospital, at which births are planned to occur away from the pregnant individual's residence following a low-risk pregnancy, and that provides prenatal, labor and delivery, or postpartum care, or a combination of them, as well as other related services in accordance with the scopes of practice of the healthcare professionals practicing at the center. So that's kind of getting at the question that was just asked, I think, of Senator Gulick, which is what types of services, and would there be a physician? I think it would depend on who chose to work, but their scope of practice is not changed by the fact that they would be working even at the birth center. So then it specifies that no person shall establish, maintain, or operate a birth center in the state without first getting a license for that birth center. It sets out that there would be an application made to the Department of Health, which also does the licensure for hospitals and ambulatory surgical centers, and include all information required by the department on forms provided by the department. There would be a licensing fee of $250 that would go into the hospital licensing fees special fund and be available to the department to offset the costs of licensing birth centers. So it puts it in an existing fund. Yes.
So is it usual to have all the licensing fees listed in statute?
Yes, it's actually required fees unless, unless there's notwithstanding the requirement in Title 32 that the General Assembly sets all fees. And yes, we do have different fees for different facility types.
Then we see the fee bill.
Right, and then there are
Yes,
updates, right, there are updates, right, yes, actually, the Chair of Finance knows very well that fees are typically set by the General Assembly. And then this has a little bit of a different provision for birth centers than we have for other facilities, which says, notwithstanding any other part of this chapter to the contrary, for an application to renew a birth center's license, the health department must deem a licensed birth center, so one that's already licensed, that is currently accredited by the Commission for the Accreditation of Birth Centers, as satisfying the requirements for renewal of the birth center's license upon submission of a copy of the birth center's official accreditation certificate and payment of the application fee. For license requirements, when the health department receives an application and the fee, it directs the health department to issue a license if it determines the applicant and the birth center facilities meet certain minimum standards. First, the applicant must demonstrate the capacity to operate a birth center in accordance with health department rules. They must demonstrate that the facilities comply fully with standards for health, safety, and sanitation as required by state law, including standards from the state fire marshal and the Department of Health and any applicable municipal ordinances. They must have a clear process for responding to patient complaints, and the birth center facilities, including the buildings and grounds, must be subject to inspection by the department, its designees, and other authorized entities at all times. These are fairly consistent with other types of facilities. A license is not transferable or assignable and can be used only for the premises and persons named in the application. And then this specifies for birth centers that they may be independently owned and operated by a licensed or certified healthcare professional whose scope of practice includes the services offered by the birth center, including midwives licensed under the licensed midwife chapter and a nurse midwife certified under the nursing statutes. So there are two types of midwives under our statutes. There's the licensed midwives, what sometimes people refer to as lay midwives, And then there are certified nurse midwives, which is a type of advanced practice registered nurse under our nursing statutes. And then this specifies that no person can represent themselves as a birth center or use the term birth center in their title or advertising publications or other communications unless that person has been licensed as a birth center under this chapter. That becomes an official term. There's a process in statute, and this is again aligned with the similar processes for hospitals and ambulatory surgical centers, for the health department to deny, suspend, or revoke a license after notice and an opportunity for hearing if that finds there's been a substantial failure to comply with the requirements of this chapter. Talks about how that notice is served and when the department would file its findings of fact and conclusions of law, which gets sent to the applicant or licensee along with the board's typical or that department's typical process. As far as an appeal, any applicant or licensee or the state acting through the Attorney General who is aggrieved by a decision of the Department of Health after a hearing may appeal to the Superior Court and sets out the standards for appealing at both the Superior Court and Supreme Court level. Inspections, the health department must make or cause to be made such inspections and investigations as it deems necessary. And if it finds a violation, the department must post a report on its website summarizing the violation and any corrective action required. Again, this is all modeled on the hospital and ambulatory surgical center language, as is this next section on records. Information received by the health department through file reports, inspections, or as otherwise authorized by law must not be publicly disclosed in a manner that identifies or may lead to identification of one or more individuals or birth centers. They are exempt from public inspection and copying under the Public Records Act and must be kept confidential except as they relate to proceedings regarding licensure of the birth center. And that does not apply to those summary reports of violations that have to be posted. Then we get to rulemaking, directs the Department of Health to adopt rules as needed to carry out the purposes of this chapter. In this case, it requires, which is different from other facility types, that the rules align the regulation of birth centers in Vermont with the National Birth Center Standards published by the American Association of Birth Centers. And it specifies that the rules may include provisions regarding the scope of services that can be provided, appropriate staffing for a birth center, including the types of licensed professionals who may practice there, and a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if circumstances warrant. And then we have another kind of unique to this type of facility section that specifies that nothing in this chapter or rules adopted pursuant to it shall be construed to limit the scope of services that a licensed midwife, certified nurse midwife, or other healthcare professional working within their scope of practice may offer or perform in a space that is shared with or adjacent to the birth center. So this likely doesn't have any practical impact unless somebody is trying to use it for practical impact, in which case it says it's not intended to be used that way. Section 2, the next couple sections deal with payment. And so section 2 is adding to an existing statute on health insurance coverage for midwifery services and home births. Under existing law, a health insurance plan that provides maternity benefits must also provide coverage for services rendered by a licensed midwife or a certified nurse midwife operating within their scope of practice and provided in various settings. This would add a birth center to those settings and also add a requirement for coverage for prenatal, maternity, postpartum, and newborn services provided at a licensed birth center.
Question, go ahead.
It's really related to editing. Would we, if I have some suggestions, some changes that I would like to make, would that be during the markup period?
That would be during markup.
Okay.
Yep.
Thank you.
Section 3 relates to certificate of need. If you remember, we walked through a couple of certificate of need bills the other day and talked about kind of what role those play in the healthcare system. And there we talked about there being some exclusions from the certificate of need requirement for certain types of facilities and providers. So under existing law, for example, physicians' offices are not subject to a certificate of need requirement. This would also add an exclusion from the certificate of need requirement for birth center, licensed birth centers.
Yeah, so, yeah, there's a thought there, and I don't know whether it fits or not. We're gonna have to wait for discussion as to whether or not we have this be consistent with the state health plan, but you know, I don't know. I'll think of that. Yes.
Yes, and it's my understanding currently that a birth center would trigger a certificate of need requirement
Yeah.
based on the numbers that we were looking at the other day. So if a facility was able to be established for less than those thresholds, there may not be a certificate of need requirement, but this would give.
Can't imagine a birthing center being
Less
getting
than the
to that
threshold,
threshold.
getting to it or being less than.
Maybe.
Which threshold? 1,000,005 or the 10 or the 5? We've got lots of numbers.
1,000,005.
The existing, I think, the existing.
Depends.
Section 4 directs the Agency of Human Services to seek approval from the Centers for Medicare and Medicaid Services, we often refer to as CMS, to allow Vermont Medicaid to cover prenatal, maternity, postpartum, and newborn services provided at a licensed birth center, and to allow Vermont Medicaid to reimburse separately for birth center services and professional services, and facility services and professional services. So it's my understanding, all of the prenatal, maternity, postpartum, and newborn services are currently covered in Vermont Medicaid, but birth center is not necessarily a setting that is recognized under our existing system. So for that to need to be amended, that's what it's directing them to. And then we have effective dates. So the act would take effect on January 1st of 2026, except it requires the Agency of Human Services to submit its request for approval of Medicaid coverage to the Centers for Medicare and Medicaid Services by July 1st, and that the Medicaid coverage would begin on the later of the date of approval or January 1st, 2026.
Okay, and meanwhile, yeah, so rules would have to be written too.
Right, that's why the act would take effect on
Yeah.
January 1st.
Questions for Jen on this bill? There's a lot here. I mean, obviously, there's everything from judicial appeals process to confidentiality of information, maybe FOIA request.
Well, that's why it's saying it is not subject.
Exactly.
It's
So, I mean,
exempt.
I don't,
Records are
well,
exempt from.
we'll have to have, and then there's the financial piece. So maybe we'll look at what we do there with that. So thoughts, is this something, I think, just on first look, is this something the committee would like to look at going forward?
Yes.
I see a lot of yeses
Yeah.
on the table. I see one maybe.
Well,
Well, we need more information.
Yeah.
then. That's good. Okay, well, I think that it makes sense. I agree. We'll put it on the agenda when we can. This will be good. Okay.
All right, which one next?
S14, let's do S14. Is it shorter bill, I think, for you and your schedule right now?
Yes, one is 4 pages, one is 5 pages.
Okay, well, let's do S14.
All right. All right, so next up we have S14, which is an act relating to expanding Dr. Dinosaur income eligibility for pregnant individuals and exploring eligibility expansions for other populations. It starts out in section 1, requiring the secretary, in this case of Human Services, to make coverage under the Dr. Dinosaur program established in accordance with two titles, Titles 19 and 21 of the Social Security Act, available to pregnant individuals of any age whose modified adjusted gross income is at or below 312% of the federal poverty level for the applicable family size. So it's my understanding that this coverage is currently available to pregnant individuals with modified adjusted gross income at or below 208%. So this would be an increase from 208% of the federal poverty level to 312. Then just a language change on line 11. And then section 2 is looking at expanding eligibility for other groups. And this would direct the Agency of Human Services to examine the feasibility of, consider the need for a federal waiver or amendment to Vermont's global commitment to health, section 1115 demonstration, or both. So I'll shorten that one. Examine the feasibility of, consider the need for federal approval, or develop a proposed implementation timeline and estimated costs of implementation for, and estimate the programmatic costs of expanding eligibility for Dr. Dinosaur to all Vermont residents up to 26 years of age with incomes at or below 312% of the federal poverty level, and expanding eligibility for Medicaid for adults who are 26 years of age or older, but under 65 years of age and not pregnant, to individuals with incomes at or below 312% of the federal poverty level. So some of that is sort of consistent with language, more directive language in S1.
So I'm looking at our federal poverty level up here, and we have 300%, we have 317%. We don't have.
So 317% is generally the actual as implemented. There's a 5% disregard. So in practice, it would be 300. It would be 317, but 312 is the kind of official number plus a 5% disregard. So if you look at the 317% column, I think you are getting the same people who would be
Getting the same people.
And I defer to DEVA or AHS to explain to you the difference.
Okay, good to know.
I still find it funny that this bill would include me because I am a Vermont resident, 26 years of age, with income at or below 312% of federal poverty level. Still kind of funny.
All right, and then this would require that the Agency of Human Services report.
When we stop there, can you answer his question? Because I think right now people can be under the commercial insurance up to 320, up to the age.
Yeah,
Was there a
I
question?
wasn't asking.
There wasn't a
No, it's not a question. Okay, okay, we'll get there. We got there.
Right, just identifying the bill.
Yeah.
With some of the people described it.
Yeah.
All right. So this would require the Agency of Human Services to report by January 15th, 2026 to this committee and others regarding the feasibility of expanding eligibility for Dr. Dinosaur and Medicaid as set forth in subsection A, any federal waiver or global commitment amendment needed for the eligibility expansions, the process for getting any necessary waiver or amendment, and the likelihood that we would receive it, the costs of the eligibility expansions, both programmatic costs and technological and operational costs, and a reasonable timeline for implementing the expansions. Section 3 appropriates $600,000 in fiscal year 2026 to the Agency of Human Services to implement the Dr. Dinosaur eligibility expansion for the pregnant individuals. And then it splits that out into the amount that would be general fund, which is $180,000, and the amount that would be federal funds or federal match, which would be $420,000. And this is, I believe, for a half year because this takes effect on January 1st, 2026. So that would be for the 6 months of 2026 that are still in fiscal year 2026. And everything else would take effect on July 1st.
I mean, so anything, if we leave any appropriation in here, obviously it goes down the hallway.
Right, whether you leave the appropriation in or take it out, if you
Right.
spend the money.
Regardless of what we do there.
If you impact the insurance market, it should show up.
Yeah.
On my side.
Go ahead.
I just want to say what I like about this bill is that it seems to kind of level the playing field. My children were covered under our insurance until they were 26 years old.
That's the comment.
Yeah, and so
Right.
it seems to make sense to provide it for folks who are, in this income bracket as well. So
I think this is a good time for me to go upstairs because I
Okay,
middle
thank you.
announcements, but I will come back and walk through as one if you would like. I don't think it will be.
Whatever, yeah, that would be great.
Okay.
We'll
I'll let
make,
you know when I'm
we'll-
leaving the floor.
so, we may have a process conversation. What we'll do is committee is going to take a break and come back at 10 o'clock. And we'll talk a little bit about what we're doing next week, I think. And then we'll see where Jen is, because she said it would be short.
Okay.
Is that good? But you're right. I think right now, commercial insurance, kids can stay under the umbrella of commercial insurance until they're 26, but that isn't the same case for kids who are up to 26 and who are eligible for Medicaid, except at lower level.
Yeah.
Any level. So, okay, so Kiki, we will take a break and then we'll be back at 10 o'clock. First, before we do that, any interest in taking this bill up?
I am interested.
Yeah, anybody? Looking at it? Taking tests?
Yeah, I've got my insurance market.
She's got her insurance market hat on, but we'll look at it. I mean, commercial insurance is already, it has some of this, so it's really about Medicaid and what we can do and if we can do it. And it requires a waiver process and everything else under the current federal conditions.
But if you,
Oh,
yeah, but it depends on if you were taking people, I guess if they're Medicaid eligible,
yes,
but we are taking healthy individuals out of a very small insurance pool.
so yeah, so there are two questions in the bill. You're right. One question is about the pregnant individuals and then covering them into Dr. Dinosaur.
Right,
And then the other question that's here is about kids up to the age of 26 and holding them under
mention that
Medicaid.
section to me.
Huh? Expanding that. There are two different things there. And so before
And then up
we,
to 26 was the concern.
yeah, so
We did that, again, trying to cut down on the uninsured. But when we did that, you could be 25 and working for a tech company and making $150,000 a year. And
it wouldn't fit.
it would, no,
Yeah,
but yeah, when we increased the age that you could stay in your parents' insurance,
right.
26, we took a certain block of college graduates who got out and got a really good job
Yeah,
out of paying into the insurance market. And the more healthy, generally young individuals we take out of the market, a greater percentage is older, less healthy, and the cost.
higher
goes-
cost.
Yeah,
Good. So, well, I'd like to look at it at least to understand the implications and certainly covering for pregnancy seems to me
the pregnancy, I think
Really
I signed on to
legitimate.
that,
Mhm.
but I was signing on to the pregnancy. Neglected to mention the 26-year-old.
yeah, no, I know.
Well,
Well, that's
Senator
also-
Douglas got it, so, huh?
It's also a study, right?
Yeah, there's
Yeah,
just
the
that.
patent parties.
Yeah, we can, so there's a lot to think about in
Yeah.
this bill. We'll put that with, S18, so S18 and 14, we'll try and put on the earlier list and see what we can do. Okay, so now